Good morning. I hear we're live. Thank you. And welcome to Axiom Healthcare Strategies Town Hall on GU tumor types. I'm honored to introduce this morning 3 leaders from the field who have agreed to join us and share their perspectives on some of the ASCO developments in bladder, RCC, and prostate cancer. So we are joined this morning by Dr. Petros Grivas from Fred Hutch, Dr. Scott Tagawa from Weill Cornell, and Dr. Matthew Smith from MGH. And as we're getting started, just a quick note on technology. Today's session will be recorded and will be available if anyone would like to review it or misses a section and wants to go back and check it out after the fact. And the town hall format allows for questions from you, the audience. So please feel free to submit any questions or comments you might have to the panel through the question and answer functionality, which you should see at the bottom of your screen if you bring your mouse down to the bottom of the screen. So what we're going to do is we're going to have, as you see, we have 3 different tumor types here today. We're going to walk through each abstract, and then we'll have a few minutes to discuss questions for each tumor type. So we'll do all the bladder content and bladder questions, all the RCC content and RCC questions, all the prostate content, and then the prostate questions. So now I'm going to go ahead and pass it over to Dr. Grivas, who will introduce IMvigor 10 in bladder cancer.
Thank you very much, Anne, and welcome to the audience. ASCO was a very busy meeting in terms of GU content, and I would like to start the discussion by very quickly summarizing the data from the IMvigor 010 adjuvant trial that evaluated the role of atezolizumab, an anti-PD-L1 immune checkpoint inhibitor, versus active surveillance or observation in patients with resected bladder cancer, muscle-invasive bladder cancer, or upper tract urothelial cancer. And as you see in the left upper corner of this slide, the design, it was a randomized design in a phase 3 trial with disease-free survival encompassing recurrence or death as a primary endpoint. And the key secondary endpoint was overall survival. The population included patients who received or did not receive neoadjuvant chemotherapy. And as you see in that slide, there are specific eligibility criteria. Patients were stratified based on the numbers of lymph nodes resected, prior neoadjuvant chemotherapy or not, lymph node status and tumor states at pathologic review at the time of radical surgery, and PD-L1 status. And as you see, the primary endpoint, disease-free survival, did not differ significantly between the 2 groups. So atezolizumab did not improve the disease-free survival in this setting. And as you see also the overall survival, based on this analysis that might be underpowered in terms of events, the secondary endpoint of OS also there was no difference. And as you see also in the left lower corner, the disease-free survival was not different based on the PD-L1 status in terms of the difference in recurrence or death. I will pause here and I will ask Scott his first impressions about this data. And do you, Scott, think that this is a class effect, or do you think we should still accrue in the other adjuvant immunotherapy trials, or any other comments you want to make? And then I will ask Matt for the same thing.
So I was quite disappointed in this trial because this is to increase the cure rate rather than just increase overall survival. So I was quite disappointed. You know, I'm a medical oncologist, so I always have some optimism. So I do have some hope for the other ones, whether it is, you know, particular to the study population, whether PD-1, you know, we think is at least a little bit more efficacious than PD-L1. You know, I don't know, but I do have hope for the ongoing studies.
So if you have, I don't know if you have the ambassador trial open at your institution. I have it open and I continue to accrue into that, but would you do the same?
Yes, we have it open, and you know, as part of the informed consent process, I mentioned this study, yeah, patients that have already had neoadjuvant chemotherapy, never residual disease, I continue to enroll those patients.
And just for the audience, ambassador is the adjuvant pembrolizumab versus observation run by the cooperative group, and there is also another trial with adjuvant nivolumab versus placebo And now we have also targeted therapy trials like adjuvant infigratinib versus placebo for selected patients. So I think it's important to continue accruing in these adjuvant trials. Matt, any comments on your part about the IMvigor 010 study?
Yeah, so it's great to see all this activity in bladder cancer. And this trial was, I think, very well designed, well intended, well executed. And I share the disappointment with the results. We certainly hoped for more. I don't believe it invalidates the approach in the other trials. I'd like to see those trials move forward, but it clearly does raise some concerns that there could be a class effect here and perhaps diminishes the probability of success for those other trials.
Yeah, and I agree with you guys. I do the same thing. I still accrue to other trials, but I as part of the consenting process, I mentioned this trial to people. So the last comment I would make before we move to metastatic disease is that there's a number of neoadjuvant trials that also have an adjuvant component, right? The perioperative kind of design. Would you have any concern with those trials, or you would still pretty much enroll into them because they ask kind of a different question as well? Neoadjuvant and adjuvant.
Yeah, I don't have a concern, and maybe that's an advantage. So these drugs work adjuvantly in melanoma, but maybe it's something that is different. And the major phase 3 in kidney, for instance, has a neoadjuvant component. So maybe that tumor immune system needs a bigger tumor burden to become activated. It's a hypothesis. So yeah, so I would have no problem enrolling in a neoadjuvant study that happens to continue post-surgery.
Matt, would you agree?
Same thoughts, I agree.
So I totally agree with you guys. So clinical trials is always the right way to go to generate knowledge. So very important study, despite not meeting the primary endpoint, still important knowledge, and we keep accruing in other trials. Anne, could you move to the next slide? So on the contrary, we had the very positive, I would argue, in terms of the primary endpoint, Javelin Bladder 100 trial at ASCO, and this was presented, the previous trial, the IMvigor 010, was presented by Maha Hussein as an oral presentation at ASCO. And this trial, the Javelin Bladder 100 trial, was presented by Dr. Tom Powles at the plenary session at ASCO just a couple of weeks ago. And both presentations were really fantastic. The Javelin Bladder 100 trial asked a different question. We now have moved from the adjuvant to metastatic disease setting in the front line. People may get chemotherapy, cisplatin gemcitabine or carboplatin gemcitabine. And usually people get 4, 5, or 6 cycles of chemotherapy, depending on the degree of response and tolerance. We can discuss about how many cycles you give in the frontline setting. But the Javelin trial was designed in a way that after the end of chemotherapy, of induction, let's say chemotherapy, with either regimen, patients were randomized between avelumab, anti-PD-L1 plus best supportive care, or best supportive care alone, with a primary endpoint being overall survival, in 2 populations, all comers, regardless of PD-L1 expression, as well as patients with PD-L1 positive tumors. And as you see in the right upper corner, as Tom presented at ASCO, the study met significantly the primary endpoint of overall survival with a hazard ratio of 0.69 in all comers, with a median overall survival exceeding 7 months. In all-comer population, and as you see, there was also a positive difference with hazard ratio of 0.56 in the PD-L1 positive tumor subset, again suggesting that this might be the new standard of care. This is practice changing the way we treat this disease. In the lower part of the slide, you also see a statistically significant progression-free survival benefit. This was almost doubled in the patients getting avelumab versus best supportive care alone. There were also significant discussion points regarding the proportion of patients who get subsequent therapy in either arm, with about 62% of patients getting subsequent salvage therapy in kind of second line and beyond. in the best supportive care alone arm, and about 44% getting specifically immune checkpoint inhibitor as salvage therapy. So after the plenary presentation by Tom, Dr. Plimak gave a fantastic discussion, and Dr. Chueri also included that in the ASCO GU highlights. So significant discussion ensued that, and right now I think we're all discussing this and whether this practice changing. So let me start with that question. Scott, we'll start with you first. Do you view this study as practice changing, and any comments you want to make on the results?
Yes, I do see this as practice changing. You know, particularly as we'll mention, you know, in the setting of the resulted and just semi-resulted, meaning press release, other studies. So rather than post-platinum progression, where we know that PD-1, PD-L1 work, you know, in the frontline setting, whether it's at the same time, which is a little disappointing, versus sequentially for those that have had a benefit, so at least non-progressive disease. I think it's important to mention that those 15–20% that have primary progression on platinum, that's just the regular other data set. But those that have non-progression, add this in, and you know, the vast majority of those I would treat. You know, one minor comment is lymph node only disease, CR. I don't know that this is necessarily needed. Most patients had PRs on this particular study, but anyway, I do think this does represent a new standard of care for the majority of patients.
I agree. This is practice changing, in my opinion. And just to make the point that the patients who entered the Bladder 100 trial were those who had response, CR or PR, or stable disease to induction chemotherapy. Those who had progression moved on off study and went to a second-line therapy. Matt, any comments on that and your practice changing and any other suggestions in these results?
No, these are practice changing results for sure. I agree with what's been said. I agree with Scott's point too about the occasional patient with the CR to chemotherapy. It doesn't look like there were many such patients in this study. If you look at the control group, median PFS was 2 months in the control group. So these are patients who are really destined to progress and progress quite quickly. So this is a great option for such patients.
I totally agree, and in full transparency, I'm the senior author in this study, but I really want to, check with my colleagues who review this in a critical way, and the feedback we're getting here from both of you and from others that this is practice changing. Let me ask both of you, based on the literature, we see that the proportion of patients who actually make it to the second line of trial in a real world setting is not as high as we want it to be. And this proportion of people who make it second line is between 25 and 55% based on retrospective and prospective data. So this 62% here in this study in the best supportive care arm, to me, looks relevant, but I want to pick your brain and how do you think meaningful it is? And because there was no crossover in this study, would you still feel comfortable with the result? And do you think this amount of patients who got second-line therapy on the control arm is still meaningful?
I think it's a well-done study, and it's not officially a crossover, so it is kind of a real-world type of an approach. Even if you look at the true crossover studies, like Matt Galsky's study, not everyone gets it for a number of different reasons. Patients with metastatic urothelial carcinoma are prototypically former smokers or current smokers, have other comorbidities, and just making it through platinum is not necessarily the easiest thing.
Matt, any comments?
No, I think the points made just reinforce the importance of this trial, the low rate of subsequent second-line therapy in the general population, and the relatively high proportion in this study just serve to reinforce the strength of this. I think these results can be readily generalized to the larger community.
Fully agree with both of you. We can move to the next slide, Anne, and I think put that data in context. I think we discussed before that Scott alluded to that the frontline trials with concurrent combination chemotherapy and immunotherapy did not show so far overall survival benefit. And what we're showing in this slide is the IMvigor 130 very quickly had 3 arms. Arm A was platinum gemcitabine and atezolizumab. Arm B was atezo alone. Arm C was chemotherapy, platinum gemcitabine plus placebo. And as you see in the right upper corner, there was no significant overall survival benefit in the interim analysis. Of course, there is longer follow-up pending. The study met the PFS endpoint, and you can argue whether the 2-month median PFS difference is clinically significant or not. But I think many of us still think that the IMvigor 130 did not change practice just because of lack of OS benefit. Let me get the quick comment from both of you about that study.
I agree with your overall summary. It did not change practice. You know, the study design issue is that it was the investigator decision which platinum use. It wasn't, so cisplatin eligible by Galsky criteria patients could receive carboplatin, and that I think hurt the study.
Thank you, Scott. Matt?
Yeah, and I guess the small PFS benefit and no OS benefit, particularly in the setting of knowing that early sort of maintenance therapy in the prior study improved OS, I think there's probably going to be less enthusiasm about the combination upfront.
I agree. And the interesting thing we don't show in this slide is that the overall response rate were similar between chemo atezo and chemo placebo, 47 and 44%, suggesting that there was not much additive role there in terms of response rates. So we're waiting for the longer follow-up in this study. And can you forward to the next slide? So we also had a couple of press releases that happened recently, and both regard first-line trials. The Danube trial compared durvalumab plus tremelimumab combination versus chemotherapy in all comers, but also durvalumab alone in PD-L1 positive tumors versus chemotherapy. And this trial was negative, did not meet the primary endpoint. And also 3 days ago, there was a press release from the Keynote 361 evaluating chemotherapy plus pembrolizumab or pembrolizumab or chemotherapy without immunotherapy. And again, statistically speaking, the study did not meet the primary endpoint. Let me get your quick thoughts on this before we move to the next section. We have pretty much 3 trials now did not meet primary endpoint, did not meet overall survival in the concurrent chemo IO setting. Scott?
You know, again, highly disappointing. I think there's a couple ways to look at this. One is cisplatin just, I mean, these are not only cisplatin, but platinum-based chemotherapy is really hard to beat is one way to look at it. So meaning we have good existing therapy. So that's the positive spin. And we do have follow-up, particularly with maintenance. But, you know, especially these two, I want to see the details of these two to figure out, you know, is there a subset that's out there? And there's still 2 other phase 3s, but one other of the 4 that were kind of started before, which is the, you know, the Danube equivalent with a non-chemotherapy investigational arm, you know, Ipi-Nivo, is that going to work? We'll see.
A good point, Scott. Matt, any comments on your end?
No, I just want to help you kind of wrap up this section. So I think we're almost over time, but you may want to go to the Q&A and see if there's, Petros, and see if there's particular questions that you want to address from the audience.
Yeah, and absolutely. And just to clarify that the Danube trial did not contain chemotherapy or combination. It was immunotherapy versus chemotherapy, but the other 2, IMvigor 130 and Keynote 361, had chemo-IO combination. One question was, how do you perceive PD-L1 positive versus intended to treat population? I suppose this is for the Javelin trial, and I will tackle this quickly. I will just say that the overall survival and benefit was in all comers, and I think the practice implications in Javelin, in my opinion, is in all comers based on that result, and there will be more details in the manuscript regarding the PD-L1 negative patients. And then some people, I will ask this question quickly to both of you. How do you see pembrolizumab as switch maintenance? Because Javelin was done with avelumab, generating level 1 evidence. Any comments regarding pembrolizumab? There was a study by Matt Galsky in the maintenance setting. Any quick comment on that? Scott?
You know, I don't think it necessarily applies. I do think there's kind of level 2 data or 1B data, whatever you want to call it, because of the other data sets. But, you know, really the phase 3 that proved it was with avelumab. That's my plan to use it, even though Q2 weeks versus the option for Q6 weeks, which is always relevant, particularly relevant with the pandemic.
Thank you, Scott. Matt?
I agree. I always prefer to go with the, you know, level 1 evidence, although I would speculate that there's probably a class effect and that other effective IO would have similar benefits.
And I think the last question before we wrap up this section is, I think we covered the rest of the questions in our talk. How will you decide when to treat with checkpoint inhibitors? I think the consensus here is for someone who has no progression, people will use first-line maintenance with avelumab. If someone has progression on induction chemo, would you use probably pembro in the platinum refractory setting if there was no IO in the front line, based on the KEYNOTE-45 trial?
Yeah, that's my practice.
I agree.
Sounds good. I think we covered everything, and I think there's a quick comment at the end regarding whether there is any biological difference between concurrent versus sequential chemotherapy. People comment on this in social media, different results in lung cancer. Do you have any last-minute word about the biology background? How we can explain biologically the results of the studies we discussed today? If you have a sentence or two, Scott and Matt.
I can't really explain. So obviously, you select out the worst patients with the maintenance. So that's one. But besides that, I can't really explain it. But one of the nice things is we do have all these big randomized trials with data, and some of them have some samples. So hopefully we'll be able to figure that out.
Any comments, Matt?
No, I agree. I agree with what Scott said.
Excellent. Guys, the discussion, I will pass it on, I think, to Scott to move on to the kidney cancer section, and I'll try to answer a couple of more comments in the online chat here. Thank you.
My comments for ASCO 2020 with regards to GU, I would say that there's practice-changing data for today and then in the near future for urothelial and for prostate, and interesting data, but not necessarily practice-changing for kidney. So I'm going to go relatively quickly over the section to kind of catch up. So the KEYNOTE-426 is not a new study. It's set a standard of care, and this was essentially just follow-up. A couple of points, and I'm not going to go through the study done because I think people know it and it's sitting right there. So the longer follow-up really cemented that number one is in the long run, the benefit in terms of OS remains, number one, and number two, no major differences in terms of long-term toxicity. Those, I think, are the two major differences. There were a small number that changed from PRs to CRs. So you can see CR rate was reported at 8.8%. One of the interesting aspects that's not on the slide that Betsy pointed out is the near CRs with the combination arm, the acti-pembro arm, did very, very well, close to how the CRs did, as opposed to the near CRs with sunitinib, didn't quite make it. So those of us that, really my generation and older who really are IL-2 people where it's CR or nothing, maybe we don't need to quite get CRs when there's this hypothesis, PD-1, or I guess PD-L1 with VEGF. So that's just something that came out with this particular study. And do Petrus or Matt, any other comments about the follow-up to this study?
I would point out that, I think you covered nicely, Scott. I think my two takeaways was, number one, people asked, would with longer follow-up, you see that the hazard ratio difference was less? Would that change my perspective? I would say no. I think with longer follow-up, still the hazard ratio is meaningful. 0.68 is a meaningful hazard ratio, and the curve stays separated. Secondly, there was no new safety signal. And number three, if anything, the complete response rate was higher. Some responses go deeper. So I don't think that the longer follow-up takes anything away. I think it's a valid option for the patient. The question remains, of course, in the intermediate and poor risk group, pembro, axi versus ipi/nivo, and this question cannot be answered unless there is a randomized phase 3 trial, there's some discussions being done in the cooperative groups. Matt?
No, I agree. The curves separate early. They remain separated with long-term follow-up. I don't have more to add. I agree with what you said.
Okay, so why don't we move on? There's a question about frontline therapy that we'll get back to. So there were a number of studies that looked at second or more lines of therapy, meaning PD-1 or PD-L1 pre-treated, and then something else. So some were built into the study, and some were, they got it, whatever standard of care, and then went on to a different study. So this was a study that was a standalone study, meaning they had whatever PD-1 and PD-L1 in the past, and then looked at the combination of pembro plus lenvatinib. Interestingly, there's so this slide does not show the response rate, but the response rates I thought were fairly impressive. Maybe reflecting lenvatinib only. We don't know, because this gave the combination and was not a randomized trial, but shows activity for this particular combination following prior IO therapy. To make another comment, this is an arm of a phase 3 trial that is in the frontline setting. So also kind of validates that, that trial, which is fully accrued, just waiting for the results of that 3-arm trial, which, by the way, does include a non-IO containing investigation arm with lenvatinib everolimus, which is proven in the post-VEGF setting. So, my viewpoint, interesting data, and is part of a phase 3 in the frontline setting. Any comments?
I think, Scott, you covered it very well. I always like the idea of combining IO with anti-VEGF. I think mechanistically and biologically, this strategy makes sense in terms of delivery and trafficking of T cells in the tumor microenvironment, potential positive immunomodulatory effects with anti-angiogenic agents that can facilitate IO response. However, the ultimate answer comes from trials, and I think the data is promising, and I think we have to wait, as you mentioned, to phase 3 trial. I always interpret Kaplan-Meier curves of PFS and OS with great caution when it comes to single-arm phase 1 and phase 2 studies because of potential selection bias. But I think it's very, very interesting to follow up the phase 3 study and see what happens, but definitely interesting and promising data. I will let Matt comment.
Yeah, I agree. I particularly like your comment about being careful about time-dependent variables in single-arm trials, because it is very dependent on the population enrolled. Having said that, I mean, this appears to be attractive data, and I also support the comment that it really would require phase 3 to sort this out.
Okay, next slide. So this combined, so there were a couple of studies that looked in different ways, that looked, actually 3 studies, 2 of them are, I see here, the third is called Omnivore, that looked at, in different ways, similar patients, meaning patients that have had prior PD-1 or PD-L1, but then specifically looked at the addition of CTLA-4. So you can see 2 out of 3 of them here. The third one that's not here showed some similar results. So, some people, so I'd say the acceptable frontline regimens for advanced clear cell are lumped all together, either PD-1, PD-L1 with VEGF therapy, or PD-1 and CTLA-4. No head-to-head studies with that. So this looks, and some people are a little bit scared, I think, of CTLA-4. So do you need it, or can you save it to salvage? My summary of these, all the studies are that some of the patients can be salvaged, meaning there's activity in the second line setting of Ipi/Nivo, but it doesn't, my viewpoint is it doesn't look to be as good as upfront therapy. So patients that walk in the door that have already had it, this gives some rationale to add it in, add in the CTLA-4, but I think that it's best when given up front.
I agree. I think if a patient comes to the clinic, especially with intermediate or poor risk, I think we discussed before about VEGF-TKI plus IO. but Ipi/Nivo is also a great option for those patients, unless there is a contraindication, active autoimmune disease on steroids or something. But I agree with you. I think it's very difficult in these studies to discern how much added value comes from the salvage of anti-CTLA-4. I think the studies are very nice and interesting, but I would definitely prefer an upfront combination of Ipi/Nivo intermediate and poor risk patients, unless there is some exception, rare patients, again, with your word about the combo with some remote autoimmune disease. I think the combo upfront makes sense overall as a rule. Matt?
Nothing to add. I agree.
Okay, next slide. So there were a couple of studies that included non-traditional VEGF or PD-1, PD-L1. So this is one of them. So this is for a subset of cancers, papillary renal cell carcinoma. And we know a subset of papillaries are driven by MET, particularly the inherited version. Savolitinib is a MET tyrosine kinase inhibitor. So enrolled patients with papillary RCC and savolitinib versus sunitinib. The study was stopped early, which I knew the study was stopped early, but when Tony presented us, I kind of learned that was based upon a totally different study. And in my viewpoints, that was a mistake because this looked pretty good. So a combination of at least a trend for improvement in terms of efficacy, and the overall toxicity rate looked better, that this drug might be better tolerable. So disappointing to me that this study wasn't fully accrued and finished. I don't know what would have happened, but non-clear cell in one way remains an unmet need because we don't have a lot of randomized data. That being said, it does look like some of its existing drugs, have activity based on single-arm phase 2 studies. I'm talking more about other studies rather than this, but any comments?
Yeah, I agree, Scott. We always struggle with these dilemmas, right? If something looks really better, would you stop the study prematurely and declaring victory? I agree with you. I think, scientifically speaking, would be nice to have a fully completed, clean, enough powered, adequately powered phase 3 trial to answer the question more definitively and leave no doubt kind of thing. There was clearly, a benefit trend, but I think having the statistical rigor, really helps. So, I agree with your comments.
A couple thoughts. I'm impressed with the great names that the RCC trials have. In the earlier trials, very, very impressive. Well done. And really, to your point, Scott, really there is this big unmet need for the non-clear cell histologies, and sort of looking at this, does seem to be a shame that it couldn't have taken it to completion to really find out if there was a benefit here, particularly given the limited high-level evidence for management of this patient population.
Okay, let's keep moving for time's sake. Next slide. So the HIF pathway clearly is important in renal cell, particularly in clear cell. MK6482 is an oral HIF2 alpha inhibitor. There were data presented by Tony Schwery in a pre-treated clear cell renal cell carcinoma population. This was a study presented by Eric Jonash of patients with von Hippel-Lindau associated RCC in the frontline setting. So first of all, getting a study done with 61 patients with VHL, I think was excellent. And this study really showed that the drug has activity with a pretty good safety profile. Safety, because it's not on here, I'll mention anemia is a thing that stands out, which would be completely expected based on the mechanism of action. So the response rates and the other efficacy parameters are at face value higher numbers than in Tony's presentation in clear cell all comers, hereditary VHL associated, but Tony's also was in the second and third and fourth line setting. So I don't know that matters so much, but it's fairly clear that inherited VHL is going to be if driven. Comments?
I think, Scott, you covered it well. I just want to emphasize one more time the unmet need, highly unmet need, for new agents in non-clear cell RCC that you mentioned before, but also here in VHL associated. There is inherent biology suggesting that VHL is important in RCC, even in sporadic. But here you have an VHL kind of association. Think about also germline mutations. I think the data is definitely interesting. You have an overall response rate of 28%. The sample size is small, but again, this is not easy to accrue in these studies. So data is meaningful, and I think both Eric's and Tony's presentations were very relevant on a virtual ASCO.
So I think this is the last slide on kidney. So I'm looking at some of the comments. There's actually some of the, or maybe there was comments still on urothelial. So putting these together. So one of the questions is VHL common. So inherited or germline VHL is a very small subset of RCC patients. The 3P somatic alteration or silencing of the VHL gene in clear cell renal cell is quite common, which is why we initially went back to VEGF target therapy and continue to use VEGF target therapy. So that's just an answer. So I think there's a few other things, but actually let me just, so one of the questions is beverlontinib, separate trial, not really a randomized trial because this was an early phase, stopped phase 3, but better in terms of PFS. I don't know that I would say that combination is necessarily better. It, on a very practical basis, happened to have drugs out there that at least one of them could be obtained off-label. So that wouldn't be a common approach for me to use personally, but that's just the comments out there. So the main one is on Keynote 426. I'm just going to read it for people. Increased CR rates in higher OR than Ipi/Nivo. What factors? So, for me, coming from high dose L2, I'm thinking IO and I'm thinking CRs. But one clear difference is Ipi/Nivo is really, that study is primarily for intermediate and poor risk, whereas the Keynote 426 study was clear cell all comers. So that is a fairly clear difference in a good risk. Very clearly, some of those good risks I think could be observed, but for someone they want to treat, then I think the VEGF PD-1 combination is fairly clear in that setting. Besides that, I think it becomes more difficult, and it looks like most or more academic centers use Ipi/Nivo, community more Pembro. Without randomized data, it's hard to say. So for a community practitioner that doesn't necessarily see a lot of these patients, I think learning to use a regimen and learning to use that regimen well is my advice. Any comments?
Scott, I think you covered it very well. I don't think we have a definitive answer in the intermediate and poor risk unless there's a randomized phase 3 trial that will probably happen if it happens to the cooperative group. But I think the data in the good risk in totality, I think there is more clear, I would say, benefit with pembrolizumab versus sunitinib in the trial Keynote 426. Compared to the trial with Ipi/Nivo versus sunitinib for the good risk. So for the good risk, I think more people will probably get VEGF TKI plus IO. Intermediate and poor risk, the jury is still out there.
Okay, I think we're ready for prostate. Matt's going to lead this section.
So here we go. Big news in prostate cancer is FDA approval of 2 PARP inhibitors in recent weeks. The FDA approved rucaparib based on the results of the phase 2 Triton-2 trial. This was a study of patients with mCRPC and disease progression despite prior AR-directed therapy and at least one prior taxane. Patients were selected, molecularly selected for having DNA repair deficiency, the list of included genes is shown there. Single arm trial, all patients were treated with rucaparib. The study was limited to patients with measurable disease. And then the primary endpoint was this intermediate endpoint of objective response rate, 44%, with the median duration of response not yet reached, with a lower confidence interval of 6.4 months. So this result led to the approval of rucaparib in molecularly selected patients with refractory mCRPC. And there is an ongoing Triton-3 randomized trial that will confirm that result. So that was 1 week, and then the following week, the thunder was taken away when the olaparib was approved following Monday, I think, based on the results of the phase 3 PROfound trial. So similar patient population, in this case randomized though to either olaparib or physician's choice of other basically AR targeted therapy. And then with endpoints of radiographic progression-free survival shown there in figure C, nice treatment effects with a hazard ratio of 0.49, and the interim analysis for cohort A, which was the patients with BRCA1, 2, or ATM mutations, showing a benefit in terms of overall survival with a hazard ratio of 0.64. So the results of this study led to FDA approval of olaparib in molecularly selected patients. So this is an important sort of practice-changing result. We've known about the activity of PARP inhibitors in molecularly selected prostate cancer for some time, but now we have FDA-approved drugs and likely more to come. So Scott, how will this change your practice, and how will you be screening patients for consideration of this treatment?
So the change is that it's now standard of care rather than having to use off-label or putting them on a trial. That's just for me personally. I think that the message is we need to test these patients. So somatically, germline, I generally do both for my patients, but there are no patients out there if no patients are tested. So I think that's the main message for the community, is that we need to test. We can do it with blood. So germ clearly can be there. Cell-free DNA can pick up some, although it's not as sensitive. So for those that don't have centers that are able to do bone biopsies, for instance, but I encourage all my patients with metastatic CRPC to have at least one tissue collection so we can go into deeper coverage.
Thank you. And Petros, do you have a preferred method of screening? What is your local practice or your preferred practice for identifying patients who may be a candidate for PARP inhibition?
Right. So, Matt, we have an internal assay called UW, University of Washington Oncoplex, that is run by Dr. Colin Pritchard. And this assay is a somatic next generation sequencing assay that we have a study for it. So many patients get that through that study. I pursue both germline testing separately and somatic testing separately. In most of the patients, if not now all the patients, I think somatic testing probably should be done to everybody with metastatic disease, especially with these approvals and clinical trials, but I think many of them also qualify for germline testing. So we have an internal assay, but I think different institutions may have different strategies and approaches, but I would strongly urge the practicing providers, even in the community, to pursue a validated assay with somatic testing. And again, many patients may require germline, but I would also caution that there will be some layer of scrutiny of how to interpret the results, because as we all know, there's a lot of nuance in the mutations, functionality, functional impact, heterozygous, homozygous. So I think we have to overall think about how we can interpret the results and provide support in the interpretation across practices, also in the community setting.
I agree, and I think there's a lot of emphasis out there about which drug, which PARP inhibitor, but I think the more biologically and perhaps clinically important question is the one you just posed, which is which assay, which gene, which mutation, and that's one of the questions. Says, can you comment on BRCA1 to ATM versus other HRD genes in terms of response to PARP inhibitors. So I'll take that question. It really looks like if you look in the detailed data from the PROfound trial and results of other studies, it looks like the major activity really is primarily in patients with BRCA2 and BRCA1 mutations with less activity, or some would argue very little activity in ATM. Not everyone would agree with that. And then various activity in the less common mutations. So the approvals were broad. They include positive biomarkers. And that way, I think the FDA got it right in that it gives clinicians discretion about who to treat. But it is worth pointing out that we believe that most of the benefit is in BRCA1 and 2. And so it's also reasonable, I think, to set patients' expectations in the right place in that regard. Got another question. Said, in patients with mCRPC post-docetaxel and ABI BRCA mutated, would you offer cabazitaxel plus carbo or cabazitaxel alone? I guess this is getting to the role of carbo in these patients. So Petros, do you want to comment on that? Is with this evidence with PARP inhibitors, is carbo just as good? Can we use carbo instead of a PARP inhibitor?
No, this came up recently, Matt, in our internal GU group here at the University of Washington. And the challenge is that we don't have good level of evidence to answer this question. Obviously, carboplatin, is a cheaper drug by itself when you in average sales price, but of course there are infusion, costs with it and, facility fees for the infusion. But I don't think we have any good comparative effectiveness studies between PARP inhibition and platinum in terms of efficacy endpoints, toxicity and cost effectiveness. We actually have clinical trials, Matt, here that we try to look at this question. We have a study that actually starts with chemotherapy, carboplatin and taxane, and then follows with a maintenance PARP inhibition, rucaparib, and that study is called PlatiPARP, and Dr. Cheng is the PI. But I don't think we have a definitive answer to your question. And what do you do over there? You have huge experience with that.
Yeah, we use PARP inhibitors. We don't use carb. I mean, it would be a rare case that we would use a patient who otherwise didn't have access. We've actually found access to the PARP inhibitors commercially quite good to date, so we shall see. But Scott, I'm going to ask you a question. Is this data good enough to move the PARP inhibitors up the line without that formal evidence, or said a different way? What kind of patient would you be inclined to use a PARP inhibitor earlier than the approved indications for rucaparib and olaparib?
So the PROfound study did not require prior chemotherapy, so it already is by that up. So at least not requiring chemotherapy. So I feel comfortable just post, Abienza in terms of setting. I don't know that I can have a patient sitting in front of me that for sure that I can pick chemo versus something else, but in my mind, I know there's some chemo patients and some non-chemo patients. And, just because it's a pill does not necessarily mean there's no toxicity. I feel comfortable using PARP inhibitors pre-chemotherapy outside of a trial now that there's approval. But I don't think it's necessary for all comers. And I think very importantly to what you mentioned before is the mutation, I think, does matter. So this is largely driven by BRCA2, with a clear difference. Luckily, that is the most common alteration. So luckily those two match, but some of the other ones, that's when I would really use the data that we have from the randomized trial with ATM, and even BRCA1 was not so much better. So that's when I would use those kind of subset analyses.
So thanks for the great comments. I want to take some extra time in this section just because these are really such important clinical issues and really do make a difference in the clinic now. And I think big takeaway is really screen these patients. That's the key point. And then think carefully about which gene, which alteration in terms of sequencing therapies. So if we could go on to the next slide. This is the HERO trial of relugolix. Relugolix is an oral GnRH antagonist. it was compared head-to-head against leuprolide acetate, not for cancer control, but for testosterone suppression, the same way that other GnRH agonists and antagonists have been developed. The study was positive. It showed non-inferiority to leuprolide for the primary endpoint of sustained testosterone suppression, and then actually met the non-inferiority protocol and was tested for superiority, was, I believe, deemed superior. And then the intriguing thing was that when they looked at adverse events, there appeared to be significantly fewer major adverse cardiovascular events. Although I have to say, I'm not sure that, I don't know if this statistical testing was pre-specified. It's not the ordinary approach for adverse events, but it's certainly rational in this case because of some prior experience with degarelix suggesting that there might be fewer cardiovascular adverse events with the injectable GnRH agonist degarelix. This is not yet FDA approved, but I would speculate that these results are sufficiently compelling that this would lead to regulatory approval. And then we'll have an option for androgen deprivation therapy with the key attributes being oral, and the other part not shown here, the other sort of distinguishing feature certainly from the agonist is that there's more rapid testosterone recovery after discontinuation of treatment. So Scott, is this a Me Too drug, or does this really have a place in the treatment of prostate cancer?
So I think it's a Me Too drug in terms of class, but clearly is different because of the formulation. So that's what I think is quite important. That being said, I guess because of the formulation, the testosterone recovery rate head-to-head in a phase 2 versus degarelix, same in class, it was actually even faster than that. So that part is quite intriguing for me. So I think that my hypothesis is clearly patient-reported outcomes have got to be better with that. What I don't know is it going to be a worse outcome, let's say a higher risk patient or intermediate risk patient with radiation, because it actually is a shorter time on treatment with that. I don't know. With that,
no, it's a great point, because the area under the curve of testosterone would be different, but would that confer the same cancer control?
Right.
Because we only know what we know. The randomized trials were done with the injectable drugs. So that's the question. The other, I guess, the advantage, of course, is the antagonist is that you get more rapid T suppression. In our practice, that's really where we use degarelix in patients who are, extensive volume disease, and we worry about flare. My worry here, though, is with an oral, how would that work? You'd have to write a prescription, get insurance pre-authorization, and the patient would get the drug in a week or two. So I can achieve faster T suppression in clinic by giving him degarelix today. So do you worry about that issue, Petros? Where do you see a place for this drug?
Yeah, I think this is a great discussion, Matt and Scott. I think the results are very, I would say, important. But and I congratulate definitely the authors for this large study, almost 1,000 patients. But there are some logistical challenges that you pointed out. The oral formulation, compliance, right, on the patient standpoint, absorption issues in some patients with GI issues, copay, insurance, and I think cost is one of the major barriers here. We know that oral medications have copay issues in prostate cancer. The other niche will be patients maybe with higher risk of cardiovascular events. I think that even more relevant to those patients, but and how does it compare to degarelix, right? That requires just a visit, and so I think the results will probably apply because of those barriers to only a proportion of patients, because of these logistical challenges. And we don't know exactly, again, the relugolix versus degarelix, comparison, because we don't have the data. But overall, we're all very worried, and that's a message for the audience, how to optimize cardiovascular disease risk factors overall in this population of patients to reduce those events.
Very good. So let's move on to the next slide so we can cover the last couple of studies. So this can be hard to do quickly, but there's obviously a lot of interest in PSMA-directed therapies. This applies to the majority of patients with mCRPC who are PSMA PET positive. Some really interesting information that we have now. The therapy study was reported at ASCO GU. This was a comparison of lutetium PSMA 617 versus cabazitaxel in patients with mCRPC and disease progression despite prior therapies. And as you can see there, substantial difference in the waterfall plots with a higher response proportion in favor of the PSMA lutetium and corresponding better PSA PFS, which I guess would come as the latter coming as expected, giving the higher response proportion. But is this the right endpoint to compare for these two different classes of drugs, Petros?
You know, it's a great question. I think we're all struggling to absorb the data as they come in, and I think there are some nuances and differences with the different drugs. I think that the lutetium 177 probably has, you know, more data in terms of the level of evidence, in terms of the arrays. I think that there's, as with every you know, similar question, there's a class effect in the individual nuances in the drugs, in the tracer, in the antibody target. And I think at the end of the day, what will guide practice will be level 1 evidence and efficacy and toxicity. And I think the data is very interesting, and I'm glad we had the chance to see them at ASCO.
Yeah, I agree. I look at this as certainly strong supportive data and just increases all of our interest in seeing the phase 3 vision data when available. In the interest of time, I'll just quickly comment on the Harpoon trial, HPN 424. This is a TriTAC, or a BiTE that has also a albumin binding domain to increase its half-life. So redirecting CTCs to PSMA positive cells is the approach. This is the results of the phase 1 dose escalation study, really showing the point that basically target inhibition was achieved. You see increase in cytokine levels in patients treated at the higher dose. And I don't believe it's shown here, but there were patients who had, I think at least a couple patients who had post-treatment PSA declines. Scott, you want to comment on your take away from this Harpoon data?
Yeah, I think it looks very interesting. What I was surprised about is, I don't say a lack, but less cytokine release syndrome than I would expect, although that may, they're still in dose escalation, so maybe they haven't the doses that's going to lead to it. But I thought it was less than I thought.
Yeah, I think that's the big caveat to this trial. It is a dose escalation, and the doses, there's a wide variation in the doses that were tested. So I think this is a situation where we really do need more data. We're close to the end of our time. So let me try to take on some of these questions that I see. Scott, thoughts about the control arm in Vision? Is that the right control arm in Vision?
Well, it is in the intent, which was supposed to be post everything. So patients were supposed to have had both docetaxel or cabazitaxel, and as was clarified in an amendment, you had to prove that they're not eligible for cabazitaxel, not just refuse it with a frailty component. So I think it is because of the design and the intent. I think the entire type of therapy is more appealing earlier, and that's one of the major appeals of therapy. It went head to head. So anyway, so Vision, I think, because of what was intended, I think is right, but in the future, I think we need randomized trials with active controls like therapy.
Yeah, I think that's right. I believe they got it right. I mean, all trials are compromises in some fashion, and the definition of unmet need in highly refractory patients is a moving target. It's different with more approved drugs. It's difficult to account for all of the approved drugs in the randomized trials. So I may turn it back over to our moderator to see if we have time or how we'd like to close up the hour. Ian?
Thank you, everyone. Thank you to our physicians for joining us, as well as to our participants for sending through questions. I would like to remind folks that the recording of this town hall will be available on Axiom Healthcare Strategies YouTube channel starting next week. So if there is anything you want to come back to, you'll have the opportunity to review that or share with colleagues. Otherwise, just want to say thank you to everyone for joining us, and I hope you have a wonderful weekend.